Thank you, dear Chairman and dear colleagues. I'm delighted to see you again. Here I'm speaking for Novartis Symposium. Time is essential, and so also Entresto. Entresto is a very important drug used in heart failure, sacubitril valsartan, that changed our practice, even my practice and my patients, to the best. We know that heart failure has a progressive nature, and patients cannot be perceived as stable as we see. We can see here the cardiac function and quality of life is decreased, and the disease progression of heart failure with increasing the mortality due to the compensation, hospitalization, and frequent hospitalization through the journey of the heart failure patients. The conundrum of the heart failure, معضلة heart failure. Heart failure is an illness that consumes substantial healthcare resources, considerable morbidity and mortality, and greatly affects quality of life. كلنا بنشوف مريض الهارت فيلير ازاي بيتشال، يدخل العناية مركزة واهله تعبانين وهو تعبان ويطلع وبعد اسبوع يرجع تاني. This is a very bad quality of life. We see that mortality is about 50% of patients die within 5 years of diagnosis. And for hospitalization, in developed countries like us, heart failure is the primary cause of hospitalization in patients aged more than 65 years. And 44% of patients will be rehospitalized at least once. The quality of life is very important, and life without quality is not a life. 76% of those patients struggle to perform their daily activities with themselves and their relatives. And 63% of patients reported symptoms that are consistent with depression. For the economy, heart failure has a significant economic burden due to the direct and indirect cost, and 70% of the cost of heart failure is due to hospitalization. So mortality rates in heart failure are high, even if patients comply with the best available treatment. If we look for the diabetic patients, there is a bidirectional relationship between type 2 diabetes and heart failure. The link between type 2 diabetes and heart failure is obvious, and all of you know that. There is a relationship between them, starting from insulin resistance, endothelial dysfunction, coronary artery disease, myocardial infarction, remodeling, heart failure, leading to diabetic cardiomyopathy. And the prevalence of heart failure is about 2.5 times higher in individuals with type 2 diabetes than the general population. Up to 49% of patients with heart failure are estimated to have type 2 diabetes. The cardiovascular deaths rates were about 1.7 times higher among adults aged more than 18 years with diagnosed diabetes than without diagnosed diabetes. And this is a dilemma. The definition of heart failure recently in 2021 in the European Society of Cardiology guidelines stated that heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of cardinal symptoms which are very important, like breathlessness, ankle swelling, and fatigue, that may be accompanied by signs, for example, elevated jugular venous pressure, pulmonary crackles, and peripheral edema. It is due to structural and or functional abnormality of the heart that results in elevated intracardiac pressures and or inadequate cardiac output at rest and or during exercise. And they stated that we have 3 types of heart failure. We have definition for heart failure with reduced ejection fraction, and the mildly reduced ejection fraction, and preserved ejection fraction. For HFrEF, reduced ejection fraction, the criteria here is symptoms plus signs and left ejection fraction less than 40%. For the mildly reduced, symptoms are the same and left ejection fraction from 41 to 49. For HFpEF, preserved, it's the same symptoms, but left ventricular ejection fraction is more than 50%, with objective evidence of cardiac structure and or functional abnormalities consistent with the pressure of left diastolic dysfunction, raised LV filling pressure, including raised natriuretic peptides. Therefore, we have 50% have heart failure with reserved ejection fraction, and 50% have HFpEF preserved ejection fraction and mildly reduced ejection fraction. The decline in systolic function leads to activation of three major neurohormonal systems: the sympathetic nervous system, the renin-angiotensin-aldosterone system, and the natropeptide system. This natropeptide system aimed at antagonizing the sympathetic and the renin-angiotensin system. Therefore, we see here the neprilysin. Neprilysin degrades natriuretic peptides and other substrates, including the angiotensin II and the vasoactive peptides relevant for cardiovascular physiology. So we have to stop this neprilysin. Therefore, the neurohormonal imbalance underlying heart failure is still silently occurring, resulting in disease progression. Therefore, the evolution of Entresto or sacubitril valsartan to antagonize the neprilysin. If we stop the neprilysin, as we see here, using the sacubitril valsartan, the valsartan will stop the renin-angiotensin-aldosterone system. Sacubitril will inhibit the neprilysin, so keeping the natropeptide system acting, so we can gain many functions. And this is a story of success. What is the story of success of sacubitril valsartan or Entresto? After the paradigm heart failure that it changed our way in the management of heart failure, it's a prospective comparison of ARNI with ACE inhibitor to determine impact of global mortality and morbidity in heart failure in September 2014. The paradigm heart failure, the number of patients were 8,442 patients with chronic heart failure, taking Entresto versus ACE inhibitor in Elbahry. And there is many results were positive for the sacubitril valsartan. 20% risk reduction of cardiovascular deaths or first heart failure hospitalization, 20% risk reduction in cardiovascular deaths, 16% risk reduction of deaths from any cause, and 21% reduction in first heart failure hospitalization, and 38% lower rate of 30 days admission, with a relative risk reduction was 20%, absolute risk reduction was 4.7%, and the number needed to treat was 21, which is a small number, and it means this is a very important drug. As the number needed to treat decrease, it means it's a very strong drug. Also, this treatment with Entresto provides substantial improvement of the patient's quality of life. As we see, this is the difference between Entresto and Elbahry here, and here we can see the quality of life is starting very early in this patient by the measurement of the Kansas City cardiomyopathy score. And the trial stopped early at 27 months, convincing superiority of Entresto over the high doses of Elbahry on cardiovascular mortality as well as on the primary endpoint, which was a composite of cardiovascular deaths or heart failure hospitalization. Other studies going for the success for Entresto, as we see, the transition study. The initiation of Entresto in a wide range of HFrEF patients early after acute decompensated heart failure event in hospital or shortly after discharge was visible and overall well tolerated. Another study of success, the pioneer heart failure. Here we can see the Entresto titrated to target dose based on systolic blood pressure should be considered first line therapy for patients with acute HFrEF independent of previous RAS exposure, and the number needed to treat with was 13. Also, the proof heart failure study using Entresto reversed the cardiac remodeling. Patients experienced significant improvement in ejection fraction by 9.4%, and 25% of subjects experienced an LV ejection fraction increase of more than 13% at 12 months. Another study is evaluate. Here also another success for Entresto. Significant reductions were seen with Entresto in left ventricular and left atrial volumes, as well as the mitral EE, suggesting a favorable impact on ventricular remodeling and filling pressure. Therefore, Entresto is a story of success, is a standard of care in all heart failure reserved with reduced ejection fraction patients, from de novo or outpatient or worsening heart failure or hospitalization, as we see from this slide. What do the guidelines say for Entresto recommendation? The American College of Cardiology consensus decision in 2021 stated that here in patient with heart failure with reduced ejection fraction, stage C, we should use ARNI or Entresto, valsartan, or ACE or ARB, and ARNI is a preferred agent, but for patients whom Entresto administration is not possible, an ACE inhibitor or ARB is recommended, as we see here from this important consensus. The guidelines in 2021 for the ECC guidelines, Entresto is #1 line in all heart failure reduced ejection fraction patients as a triad of the ACE inhibitor or ARNI, a beta blocker, and MRA is recommended as a cornerstone therapy for those patients. Unless contraindicated or not tolerated, the DAPA or EMBA are recommended for all patients with HFrEF already treated with ACE inhibitor and ARNI and the beta blocker and an MRA. What is new in 2021? The Entresto recommendation, as we see. There is a very important study called the Paragon heart failure study. There is no specific trial of ARNI in HFmERF or the mildly reduced ejection fraction. In the Paragon trial, which include patients with ejection fraction more than 45%, although the trial missed the primary endpoint overall, a significant ejection fraction by treatment interaction was observed for sacubitril valsartan compared with valsartan reduced the likelihood of the primary composite outcome of the cardiovascular death and total heart failure hospitalization by about 22%, as we see here in this study. It means here in those with an ejection fraction below or equal to the median of 57, further data are available from a combined analysis of the Paragon of the Paradigm heart failure and the Paragon heart failure trial show that the sacubitril valsartan or Entresto compared to other forms of RAS blockade has a beneficial effect in those patients, especially on hospitalization for heart failure in those with mildly reduced ejection fraction. Entresto is recommended for patients with heart failure with mildly reduced ejection fraction between 41 to 49 to reduce the risk of heart failure, hospitalization, and death. This is class 2B/C, as we see. Sacubitril valsartan may be considered for patients with HFmERF to reduce the risk of heart failure, hospitalization, and death. The FDA on 16th of February this year make a statement, new FDA indication, open up use of sacubitril valsartan in heart failure with preserved ejection fraction. The ARNI is the first heart failure therapy with an FDA-approved indication that includes patients with preserved ejection fraction to reduce the risk of cardiovascular death, hospitalization for heart failure, and in adult patients with chronic heart failure And the benefits are almost clearly evident in patients with left ventricular ejection fraction below normal. The left ventricular ejection fraction is variable measure. I can make an echo and I find the ejection fraction, for example, 50. You can make another, it can be 48. You can make another, you can figure. So this is a variable, and we don't have a number for that. So use clinical judgment is very important in deciding whom to treat for heart failure. For the guidelines, there is an acknowledgement of Entresto and HFpEF in preserved ejection fraction. The task force acknowledged that the treatment options for HFpEF are being revised as this guideline is published. And they note that the Food and the Drug Administration, what I show you now, has endorsed the use of sacubitril valsartan, Entresto, and spironolactone in those with an left ventricular ejection fraction less than normal. These statements relate to patients within both the HFmERF, the mild reduced, and the HFpEF, the preserved categories. For sacubitril valsartan, this decision was based on the subgroup analysis from the Paragon study, which showed a reduction in heart failure hospitalization in those with an left ventricular ejection fraction less than 57%, and the meta-analysis of the Paradigm and the Paragon altogether showing a reduction in cardiovascular deaths and heart failure hospitalization in those with an left ejection fraction below normal range. So now Entresto, now the indication is approved in Egypt to reduce the risk of cardiovascular deaths and hospitalization for heart failure in adult patients with chronic heart failure. The benefits are most clearly evident in patients with left ventricular ejection fraction below normal. Entresto is the first and the only drug approved across the heart failure spectrum. As we see, this is ejection fraction below the normal range, below 60, as we see. This is, we can use it in the reduced, we can use it in the preserved, and we can use it in the mildly reduced ejection fraction. So Entresto is now indicated in patients with chronic heart failure, regardless of the ejection fraction. And thank you very much for your attention.
شكرا جزيلا دكتور عاطف.